Before we begin, I'd like to emphasize that this podcast is an extension of my surgical work and research at Visionary Eye Doctors. And thank you all for tuning in every week or multiple times to kind of hear about our research and how we help patients. And thank you to all of you who have flown in from all over the world to see us here. So I'm very humbled by that. So it is my hope and desire to keep this information free to all of you, especially to my dear patients. And in keeping with this mission, we are very thankful to our first sponsor for this podcast, Wizard Dry Eye Mask. Many of you have heard me talk about the Wizard before. I have loved this product for years. It looks like this. I have one right next to my bed. So does my husband. I used mine last night. And even, if I can't sleep, I'll use it. It's a wonderful product that you just plug in next to your bed or even at your computer. I've been known, if I start to develop a stye, to do the Wizard as I type and then switch, if I have warm, just like a warm compress. So it works wonderful for that. So thank you to the Wizard. If you mention our name, podcast, Visionary Eye Doctors, Dr. Kramer's, they'll give you a 1-year guarantee. If anything happens to the product, just call them up and they'll replace it for you for free. So thank you to the Wizard Research team for sponsoring this podcast. Enjoy. Hi, everybody. It's Dr. Sandy Laura Kramers. Thank you for joining us for the EYE Show podcast. Today, we have a very special guest, Dr. Andrea Laura Kossler, who is an associate professor of ophthalmology at Stanford University School of Medicine and the director of the Oculofacial Plastic Reconstructive Surgery and Orbital Oncology Service at the Byers Eye Institute. She's also the director of Stanford's Multidisciplinary Thyroid Eye Disease Center, where she works together with endocrinology to provide cutting-edge patient-centered care. Dr. Kossler graduated summa cum laude and valedictorian at Georgetown School of Medicine. I was there for the ceremony. And she did her residency and fellowship at the very prestigious Bascom Palmer Eye Institute in Miami, Florida. Over the last 13 years in practice, she has become an expert in minimally invasive techniques specializing in thyroid eye disease, orbital oncology, and aesthetic eye surgery. Her patients fly to her all over the world. They come in, children and adults, and she's known as really one of the top leading experts in her field because of her personal style and her bedside manner and her artistry, and we share multiple patients. And she is also a trailblazer in research. She has co-authored more than 100 publications, some of us together, abstracts and book chapters with a focus in advancing thyroid eye disease therapies, understanding of thyroid eye disease, its inflammatory mechanisms, and exploring novel therapies, which we're going to get into her today. She has been a well-sought-after speaker internationally, so I'm very honored that my sister, Andrea Laura, is here with us. So Dr. Kossler, welcome. Thank you for joining us.
Thank you so much, Sandy. That was definitely overwhelming and humbling to have your big sister introduce you like that. Thank you so much. It's an honor to be here. It comes full circle. We obviously are sisters, and you've been my big sister, inspiring me along the way. And being here to share my passion with thyroid eye disease is really just a joy. So let's hear your viewers about this important disease.
Yes, I'm so honored to have you on the show. Honestly, we talk about so much in terms of medicine when we talk on the phone, and I thought, well, obviously I should have her on the show, and it's only taken about 6 months to get you on the show because we're so busy. But let's start off talking a little bit of just briefly, how did you get into thyroid eye disease, and what have you kind of learned as you've helped patients over the many years to understand what is the underlying cause of thyroid eye disease?
Sure. Great question. I trained at the Bascom Palmer Eye Institute, and I would attribute what I've learned in thyroid eye disease, especially at the beginning, to my mentors, Dr. David C., Dr. Thomas Johnson, Wendy Lee, Sarah Wester, Chris Alabiad. I had so many wonderful giants and mentors that really taught me about this complex systemic autoimmune disease. And what I loved about thyroid eye disease is that it's a big challenge. Thyroid eye disease is a challenging condition to treat. It's a systemic condition, and there are many systemic and ocular manifestations of this disease. I think I was drawn to the challenge. It's also one of the few conditions that I treat where I follow my patients chronically. As a surgeon, I oftentimes see them, recommend surgery, do their surgery, and then usually I see them through the postoperative period. And it can sometimes be more transactional, whereas my thyroid eye disease patients, I really become involved in their journey, and I have to walk them through their journey and get them to the other side of this sometimes debilitating, sometimes disfiguring, sometimes vision-threatening condition. So it's really a a joy to be able to take care of these patients. And I've spent the last 13 years trying to understand this challenging disease so that I can really help my patients. So it's really been a journey for me.
Wonderful. And so if someone asks you, what is thyroid eye disease? How do you best define that?
I think the first question is, what is Graves' disease? So Graves' disease is a systemic autoimmune disease, and it impacts almost 2% of the US population. And typically, thyroid eye disease, it's the most common extrathyroidal manifestation of this disease. So 50% of patients that have a hyper-functioning thyroid or have Graves' disease can have the ophthalmic manifestations called thyroid eye disease. Now, this disease, which is a systemic disease, can impact other parts of the body as well. These patients can have changes to their skin or dermopathy. They can have changes to their joints or acropathy. And of course, they can have the hormonal dysregulation that we see in Graves' disease. So the two do come hand in hand. About 90% of our patients that have thyroid eye disease have a hyperfunctioning thyroid. But it's important to know that 10% of our patients don't, right? So don't be fooled. You can still have a normal functioning thyroid or even hypothyroid or a condition called Hashimoto's, and you can still have the eye manifestations.
So what would be some of the first symptoms a patient might notice? And a lot of us have heard of the word, a lot of our patients have heard of the word hypothyroid, hyperthyroid, but less commonly they hear the word Graves' disease or even thyroid eye disease. So what are some of the first symptoms someone should be kind of looking for?
So that's a great question. One thing that's important to know is that 20% of the time, the eye findings can happen first, before someone even knows that they have any issue with their thyroid. When you go to your primary care doctor, they routinely will get thyroid function tests. But sometimes, even though those tests are normal, 20% of the time, the eye disease can present first. So that's important, and I'll tell you what those symptoms are in a second. And then about 40% of the time, patients are getting diagnosed with their thyroid dysfunction and their eye disease around the same time. And then another 40% of the time, the eye changes can happen long after the thyroid changes. And it's not uncommon that a patient or an endocrinologist will think, no, this can't be thyroid eye disease. I've already treated their thyroid. But the two diseases can happen irrespective of each other. So you can have a completely controlled thyroid condition and still develop the eye manifestations years later. So it's really complex and confusing disease. So the symptoms that patients will typically first experience are inflammatory signs and symptoms. And again, it's complex because it depends on your age. But in general, patients will normally notice some pain or redness or swelling. And as that progresses, that can change the way that the eyes look. And so their eyelids can sometimes look a little swollen, or maybe they can lose their eyelid crease, or maybe their eyelid starts to look a little bit too open. And then sometimes their eyes start to look like they're bulging forward. And then sometimes patients can start to notice that when they're trying to move their eyes, they have a little bit of heaviness or pain or restriction. And as all of these inflammatory changes continue, then patients can develop problems seeing single vision. So they can develop double vision. Or they can even, in the worst case scenario, develop loss of their vision. So these names that we say, eyelid retraction, that's the most common thing that patients start to notice. Their eyelid starts to look like it's too open, and people call that a thyroid stare. That happens in 90% of our patients. So if a patient notices that their eyelids start to look asymmetric, they're having some pain, redness, or swelling, maybe they have a thyroid disease, those are usually the early symptoms that you want to see your eye doctor for.
Mm-hmm. And as you know, I see a lot of patients that come in with dry eye disease, and sometimes that's one of the very first signs somebody might notice. And so the pain is from inflammation, and sometimes inflammation is maybe around the orbit, you would say, or I would say meibomian glands, lacrimal glands. What part of the eye usually has the most significant inflammation?
Well, that's a fantastic point, because about 60% of patients, and I personally think that number is higher, but 60% of patients with thyroid eye disease will also have ocular surface disease or dry eye disease. Mm-hmm. And as you know, they're both inflammatory conditions. So dry eye disease is an inflammatory condition, and so is thyroid eye disease. And so oftentimes these patients are going to be coming to the optometrist, they're going to be coming to the general ophthalmologist. And so you really want to keep that antenna up to not just say, oh, this is dry eye disease. Mm-hmm. Because if you catch them really early, you can just completely change the trajectory of their disease. And so patients with ocular surface inflammation, again, it's very hard to differentiate early. So you have to just take that extra step to ask them about any thyroid dysfunction and to really do the full oculoplastic exam. And that's, of course, something that we don't always think to do, but take a look at their eyelids, take a look and potentially measure the prominence of their eyes, measure the movement of their eyes. And something that happens really early. So when I have a patient that comes in with just ocular surface inflammation, and I'm not sure if they have thyroid eye disease, I'll ask them about what happens when they first wake up in the morning. Mm-hmm. So when they first wake up in the morning, do they feel like their eyes have any additional pain or redness? Or do they feel like they have any difficulty focusing first thing in the morning, like double vision first thing in the morning? That's a pretty common thing. Or do they have a little bit more swelling first thing in the morning? And although some patients that have dry eye disease may also have a little bit more puffiness or blurriness in the morning, that's a pretty sensitive way of figuring out if they're having some type of inflammation or fluid shifts overnight that could be due to inflammation. So I'll oftentimes ask them about the temporal association of some of their symptoms. And then I'll also look at their labs, and I'll also ask them a little bit about Graves' disease symptoms. So are they having difficulty sleeping? Are they losing weight even though they're eating normally? Or maybe are they more hungry? Are they having more shakes or tremors? Are they sweating at nighttime? Mm-hmm. So all of these are things of an overactive thyroid. And so early diagnosis is by far the best thing that we can do for our patients, because if we can diagnose them early, then we can start to talk about modifiable risk factors that we can control for them to help to decrease the progression of their disease. And we can also refer them to the proper doctors, such as oculoplastic surgeons, to start management options if necessary, which can now actually change the trajectory of their disease. And it's, of course, important to get them to their endocrinologist so that their thyroid and systemic disease can be controlled.
That's excellent. That's exactly wonderful to think of it that way. It was a really important time for the general ophthalmologist, optometrist, even optician, if they notice something, to say something for sure. And one of the things Dr. Kossler and I kind of talked about off camera is the meibography as a potential diagnostic indicator for autoimmune disease, and especially thyroid disease, because it can be one of the first cells of the body that starts to show inflammation that we can now image with a very quick test. So what is the real pathophysiology behind thyroid eye disease?
That's a great question. I mentioned that it's an autoimmune disease. And so currently what we believe is that the TSH receptor, which is a receptor that's located on the thyroid gland, is also present in orbital tissues. We call them orbital fibroblasts. And so we think that the TSH receptor is the autoantigen. So we think it's what your body is recognizing as foreign, and your body is going to attack that foreign receptor. And then in more recent years, Terry Smith and this group at Michigan has done a lot of work to recognize that the IGF-1 receptor co-localizes with the TSH receptor on the orbital fibroblast cell membrane. So what that means is that these two receptors that are located in the orbit, they basically crosstalk together. And so we also think that the IGF-1 receptor is an autoantigen. The two of them can really stimulate this inflammatory and autoimmune disease. And there may even be other antigens that we need to target, such as thyroglobulin, maybe even thyroid peroxidase. So there's a lot of different autoantigens that may be responsible for starting this autoimmune inflammatory cascade. But at the very least, we know that the TSH receptor, especially in Graves' patients on the thyroid gland, and the IGF-1 receptor and TSH receptor together on orbital fibroblasts stimulate this autoimmune cascade. So your immune system, like we all know COVID, right? So we can all kind of think about COVID since we just went through this together. Your immune system's job is to send cells to surveil your body. And these cells are supposed to recognize, good things in your body and then bad things in your body. And so if the cells recognize these antigens as foreign, they're going to mount an immune response. And so your body's going to create antibodies. And this is your body's way of fighting for you and helping you and helping to fight off bacteria or viruses. But in this situation, it gets it wrong and it attacks part of your body. And so as we create these antibodies and these antibodies attack the thyroid, that causes increase in thyroid hormone. Patients become hyperthyroid. But as they recognize the IGF-1 receptor or the TSH receptor, well, then they activate those receptors. And then that results in an inflammatory cascade in the orbit. So then these fibroblasts, they release inflammatory products. We call them cytokines. That can cause inflammation, so pain, redness, swelling. But also when these fibroblasts, when these really special cells behind your eye, when they get activated, they can actually transform into fat cells. So then you get fat hypertrophy. And so that's why sometimes, especially in young women, they get fat expanding, basically, not only behind their eye, but also in their eyebrow and throughout their face. So we call it thyroid eye disease. It's actually a facial disease, a systemic disease. So fat can hypertrophy around the eye, pushing the eye forward. These fibroblasts can also differentiate into something called myofibroblasts. And myofibroblasts are what we see with wound healing. It's basically like scar tissue. And so that's why we see patients that can develop the really tight muscles that can't really, move very well, and patients can get double vision. And that's why we see the eyelid getting retracted and scarred and opening too much. And sometimes patients can't close their eyes. And so it all has to do with inflammation, causing swelling, pain, redness, fat proliferation, causing bulging and cosmetic disfigurement, and then myofibroblasts, which basically causes fibrosis. And all of this inflammation can also result in late fibrosis. So there is a really complex cascade that's involved that we're starting to really understand. And by understanding the pathophysiology, we've been able to develop drugs that can target the main problem in the disease, which is the autoantigen, the IGF-1 receptor. We also have drugs that target some of the inflammatory products in the disease, such as IL-6, IL-11, steroids, et cetera. So that's just a little bit about what's happening behind the scenes, molecularly behind your eye when you have thyroid eye disease.
Beautiful. And IL stands for interleukin, which is a marker for inflammation, which is amazing, the new technology happening. Because when I was a resident, we just had steroids, really. And so it's very exciting. What is your favorite way or best way, do you think, to actually diagnose early thyroid eye disease? So the three most important things, and this is super important because I know that, you're a world-renowned general ophthalmologist and a dry eye specialist. And I think that probably people listening are also either patients or general ophthalmologists or optometrists. And so you guys are the front lines. I mean, really the most important people in this disease. And so the first thing that we want to do, as we already talked about, is get a great history and exam. Because the clinical features of thyroid eye disease, even without the other two I'm about to mention, can clinch the diagnosis. And so the exam, as we talked about, is looking for things like eyelid retraction, proptosis, that's when your eye bulges forward. And so you can measure that with a Hertel, or you can just simply feel someone's eyes. And, some simple things are, if you look at someone from the side of their face, you should see their nose. You should not see the other eye from the side. That means their eyes are too prominent. We see. That's great.
Or if you feel their eyes, nobody's eyes should really extend anterior to the brow bone. That is abnormal. So there's a few things that you can do. Another one is that the eye, sometimes the eye is not as prominent as the cheek. We call that a negative vector. But by looking at kind of the bone structure and the relationship of their eye, if you don't have a Hertel, you can start to tell if patients' eyes are bulging forward. Or you could simply ask them to pull up their iPhone and look at photos of them from, before this disease may have started, maybe 10 years prior or something like that. So looking at the eyelid position for eyelid retraction, looking at eyes bulging or changing in prominence, looking at the movement of their eyes, making sure they don't have any restriction or stiffness or pain when they move their eyes. And then so the clinical exam, number one, and then as I talked about, the history to make sure they don't have inflammatory signs or symptoms. The next thing is getting labs. So if you could get labs, that would be wonderful. And the labs that I would get are just my typical thyroid function tests. So T3, T4, TSH. But the most important thing to get in addition to that are the antibody tests. And so there's a variety, but the most sensitive one is the thyroid stimulating immunoglobulin, TSI. And so if you can get the thyroid stimulating immunoglobulin, that is a measure of antibody that could be attacking the TSH receptor, as I mentioned, is such an important autoantigen. So getting a set of labs is the second most important thing to do, in addition to the history and the exam. And then the third thing that we do is get imaging. And so a CT scan without contrast can be done relatively quickly and less expensively. And then that will help us to anatomically better understand what's happening behind the eye. And we can take a look at the size of the muscles. So those three things can help us to make that diagnosis of thyroid eye disease. And typically we say that you need 2 out of the 3 to be sure that you have the diagnosis. But even if you have 1 of those out of the 3, you can still suspect thyroid eye disease and start to talk about risk factor control.
Mm-hmm. When you say the Hertel, are you looking for more than 20 millimeters, or is it just 2 millimeter differences between the 2 eyes?
Good question. So the Hertel is this measuring device. And so it sits here on the lateral orbital rim. It has these prisms in it, and it's trying to measure the distance from the lateral orbital rim to the tip of the cornea. On average, in a Caucasian person, that distance should be 18 millimeters. But that changes depending on age and race. And so in some of our Middle Eastern patients, Indian patients, African-American patients, sometimes they can have more prominent eyes, so up to 20 would be considered normal. And then in some of our patients that are from Asia or South Asian, their Hertel numbers can be much lower, maybe 16 millimeters. So it does depend a bit. That's why looking at the way that their eyes are in harmony with the rest of their face, or looking at prior photos can be sometimes an easier tool for someone that doesn't have the Hertel.
Very helpful. What about the CAS system and the UGO system, or UGOGO system?
Yeah, so UGOGO is a European group on Graves' ophthalmopathy. I can't even say it myself. Graves' ophthalmopathy. And so basically, UGOGO is a group of very passionate and wonderful endocrinologists and a few ophthalmologists. And they've done so much work into thyroid eye disease, Graves' ophthalmopathy, and how to treat this disease. So they've come up with recommendations in 2008, 2016, and then again more recently in 2021. And they come up with, it's a nice way to, when I was a resident, I printed out the UGOGO recommendations and I copied and pasted the exam and all of the questions I'm supposed to ask patients into my template when I first started out. And it's actually very comprehensive and helpful. Mm-hmm. But they recommend the 7-point CAS score to help to determine the activity of the disease. So to back up just one moment, when we're diagnosing patients, of course, we want to do the exam, the history, labs, and imaging, or send it to someone who can do that. But what we're trying to figure out, in addition to the diagnosis, is the activity of the disease and the severity of the disease. So thyroid eye disease is biphasic. It has an active inflammatory phase, and then it'll eventually, spontaneously, burn out into what we call a chronic or non-inflammatory phase, where the inflammation subsides, but unfortunately the sequela from the disease persists. And so we really want to try to diagnose patients early. And as I mentioned, the active phase is usually the first phase. So the clinical activity score is a way to measure the activity of their disease. And so we ask questions like, do you have any pain? Do you have any pain with movement, eye movement? And then we do their exam. And so we look for any swelling of their eyelid, swelling of their conjunctiva, which we call chemosis, and even swelling of their caruncle. And then finally, we look for redness of their eyelids and redness of their conjunctiva. And so that's the same pain, redness, swelling that we've talked about. So dolor, rubor, and color. So, the inflammatory signs. And if they have 3 or more on your first visit with the patient, you would suspect them as having inflammation or active disease. Then on a subsequent visit, let's say you see that patient 6 or 12 weeks later, if they have any worsening of their vision of 2 lines or more, if they have worsening of their proptosis or worsening of double vision, then you would add those 3 points to the 7-point CAS score. So now we have a 10-point CAS score, and 4 out of 10 or more would be considered active disease. And those last 3 points, the change in vision, the change in proptosis, or change in double vision or eye movement, are really important because they mark progression of the disease. So the first 7 marks inflammation, the next 3 mark progression of the disease. So if patients have inflammation or they're progressing, then you really want to consider medical treatment to stop the progression of the active inflammatory phase.
That's great. So you are using CAS daily. Are you having like a checklist? Is it on a app? How do you kind of put that in the record and keep track of it with patients?
I have templates for my thyroid eye disease patients, and the CAS score is already in that template. And so as I go through my list, I have a long checklist of all the things that I'm going to evaluate for my patients, ask them, and then do on my physical exam. It's one of the first parts. And so I just ask them those questions about pain. And then in my clinical exam, I assess those swelling and redness markers. And then based on that, I do use the CAS score, but mainly for research purposes. So I check it on every single person. But the CAS score is a way for us to speak the same language with other people and to measure people over time. But I have to say that the CAS score was actually developed to measure the response to steroids. It was actually never developed to measure some of the new drugs that we have now. And so, in some of our oculoplastics conferences, we don't love the CAS score, but it is a very good initial tool for us to figure out if patients have inflammation or progression. So I do encourage it to be used by ophthalmologists, optometrists, and oculoplastic surgeons.
Great, thank you. Okay, Dr. Kossler, we're going to wrap up for the first part of this podcast and then continue with the second part of thyroid eye disease with Dr. Kossler. Thank you for joining us for this podcast. Please stay tuned for the second one as well. Thank you.